Good morning, team, and welcome to This Explainer. Let's set the scene for morning rounds. Imagine we're the internal medicine residents, probably running on our third cup of coffee, and we are ready to present our patient census to our attending physician. Our big focus today? Acute kidney injury, or AKI. We're going to break down this super common yet kind of complex condition by looking straight at the pathophysiology. We've got 3 specific patients on our service today, and by the end of rounds, you'll know exactly how to localize and treat their specific kidney injuries. Okay, let's dive right into this. Here's the agenda for our morning huddle. First, defining acute kidney injury. Second, case 1, pre-renal dehydration. Third, case 2, intrinsic ATN. Fourth, case 3, post-renal obstruction. And finally, management and urgent dialysis. All right, section 1, defining acute kidney injury. The strict diagnostic criteria for our patients. So before we actually go see our patients, we need to know exactly what qualifies as AKI on our surface. We really don't want to miss a subtle but dangerous drop in kidney function. To diagnose it, we rely on the KDIGO criteria. The very first major red flag that a patient's glomerular filtration rate is tanking is an abrupt rise in serum creatinine of 0.3 milligrams per deciliter or more, all within a 48-hour window. Since creatinine is freely filtered by the kidney, when that filter stalls, well, the creatinine climbs. Another vital diagnostic clue is a drop in urine output, specifically to less than 0.5 milliliters per kilogram per hour for at least 6 hours. Spotting these numbers early is absolutely crucial because AKI is incredibly common in the hospital, and it's often highly reversible if we just catch it in time. For every single patient we see today, we're going to systematically hunt for the insult using a 5-step diagnostic approach. We start with their history and a really deep dive into the med list. We are looking for those hidden nephrotoxins. Then we check vitals and assess volume status right at the bedside. Step 3 is analyzing urine studies, which includes the sediment. Step 4 involves specific blood work, like the BUN to creatinine ratio. And finally, step 5 is imaging, specifically getting an ultrasound. Let's apply this powerful framework to our first admission. Moving to section 2, case 1. Pre-renal dehydration, the thirsty kidney. For this first case, the problem is happening entirely before the blood even reaches the kidney. Our patient presents with 3 days of severe vomiting and diarrhea from a viral gastroenteritis, which is complicated by extremely poor oral intake. I mean, this is a classic textbook scenario of true volume loss. There's literally just not enough blood volume reaching the kidneys to maintain normal filtration. But, and this is key, it's crucial to understand that the kidney tissue itself is perfectly healthy. It's just underperfused and, well, really thirsty. So, the vital physiological question we have to ask ourselves, and you know our attending is definitely going to ask us this on rounds, is this kidney hoarding salt or spilling it? Because this kidney is totally healthy. It senses that low blood volume and responds exactly like it's supposed to. It's going to work overtime, driven by hormones like aldosterone and ADH, eagerly reabsorbing sodium and water to defend the patient's dropping blood pressure. Let's take a look at the labs to see this mechanism in action. And this brilliantly illustrates the classic prerenal lab fingerprint. Because the kidney is on this massive reabsorbing spree, it pulls back urea right along with the water. This causes the BUN to climb completely out of proportion to creatinine, giving us a BUN to creatinine ratio of 20:1 or higher. The urine sodium, that's going to be super low, under 20 milliequivalents per liter. And the fractional excretion of sodium, or FANA, will be less than 1%. The kidney is avidly hoarding salt just to restore its own perfusion. On to section 3, case 2, intrinsic ATN, the broken sieve. Now we are shifting our focus directly to the filtering tissue within the kidney itself. Our second vignette involves a much sicker patient. We've got an ICU admission for severe septic shock. This systemic infection caused a state of prolonged, dangerous hypoperfusion. While case 1 was a mild, transient low-flow state, case 2 represents what happens when that low-flow state goes on for way too long. The delicate tubular cells are basically starved of oxygen, and they eventually die off. This leads to ischemic acute tubular necrosis, or ATN. The filtering tissue is now structurally damaged. Now, what's really interesting here is how perfectly this contrasts with our first patient. In case 1, our prerenal labs showed a high BUN to creatinine ratio and a very low FNA, because that healthy kidney was smartly reabsorbing everything. But in case 2's intrinsic ATN, the tubule is dead. It's basically become a broken sieve. It can't selectively reabsorb anything anymore. So the BUN isn't pulled back, which drops the ratio below 20:1, and the damaged tubule just aimlessly spills sodium into the urine, pushing that FNA above 2%.
To definitively confirm this, we look at the urinalysis sediment, which acts like a locator beacon for the injury. Our pre-renal patient had a bland sediment, maybe a few hyaline casts just from having highly concentrated urine. But for our case 2 patient, we see those classic muddy brown granular casts. These are quite literally these sloughed off necrotic tubule cells washing out in the urine. And just for completeness, keep in mind that white blood cell casts point to an allergic interstitial nephritis, while dysmorphic red blood cells would point us toward glomerulonephritis.
Section 4. Case 3. Post-renal obstruction. The blocked pipes. All right, we've looked before the kidney, we've looked inside the kidney, now we're turning our attention to the plumbing after the kidney. Our final vignette is a patient presenting with an enlarged prostate, a weak urinary stream that's been getting worse over the last few months, and on physical exam, you easily find a palpable, tender bladder right above the pubis. This is a classic presentation of benign prostatic hyperplasia, or BPH. The enlarged prostate has tightly clamped down on the urethra, causing a bladder neck outflow obstruction. Because the urine literally cannot drain, the pressure climbs relentlessly. It backs up through the ureters all the way to the kidneys, effectively stalling the filtration process entirely. The absolute cardinal rule for any patient presenting with acute kidney injury is that you absolutely must proactively rule out an obstruction. Why? Because it's one of the most highly reversible causes of AKI if you catch it early. And the absolute best tool for this is a renal ultrasound. It's cheap, it's incredibly fast, there's zero radiation, and it beautifully reveals hydronephrosis, that characteristic dilated, back-pressured appearance of an obstructed collecting system. We never ever want to miss a blocked pipe when such a simple test can confirm it. And finally, Section 5, Management and Urgent Dialysis, the Assessment and Plan. We've seen our patients, so now let's finalize the plan. For our morning presentation, we have to show the attending that we match our treatment directly to the mechanism of injury. For our Case 1 pre-renal patient, we prescribe isotonic IV fluids to rapidly restore volume and perfusion. For our Case 2 intrinsic ATN patient, the focus is entirely on supportive care. The tubule needs time to heal, so we gotta meticulously stop all offending nephrotoxins, things like NSAIDs and ACE inhibitors. For our Case 3 post-renal patient, we simply relieve the obstruction quickly by placing a Foley catheter. But remember, post-obstruction, these patients can dump massive amounts of fluid, so we have to carefully replace half of their unusually high urine output with half normal saline to prevent them from becoming pre-renal all over again. So the crucial point here is knowing exactly when conservative management just isn't cutting it anymore. We use the famous AEIOU mnemonic to remember the absolute indications for urgent dialysis. We initiate dialysis for severe refractory acidosis, dangerous electrolyte imbalances, particularly refractory hyperkalemia, certain dialysable intoxications like lithium or salicylates, refractory volume overload that's causing severe hypoxemia, and uremia, which shows up clinically as pericarditis or encephalopathy. If any of our patients hit these markers, we are paging nephrology immediately. As we wrap up morning rounds, I want to leave you with this provocative clinical checklist question to ask yourself for every single AKI admission going forward. Have we rigorously checked the med list for hidden nephrotoxins, and have we definitively ruled out a reversible obstruction? Remembering to investigate those 2 reversible factors will save your patient's kidneys time and time again. Great job on rounds today, team. Keep investigating, keep learning, and I'll catch you on the next explainer.